Good morning, everyone. Thank you for being here on a Saturday morning. COVID has really made all of us lazy, and the attendance in live physical conferences is dwindling. And even most of the presenters are opting for the virtual talks last minute. So I hope we can get back to normal soon. And I would like to thank the organizers for giving me this opportunity. So I will be talking about neoadjuvant therapy in non-small cell lung cancer, what it means for the surgeon. So I will be covering why neoadjuvant, what is the evidence that we have, what we worry about as surgeons, the morbidity, mortality, whether we can utilize it in extended resections, is it feasible to do minimally invasive surgery after neoadjuvant, what is the role of immunotherapy, how does it affect our pulmonary functions, and what is our data. So neoadjuvant therapy has been proposed to have many benefits as covered by the previous speaker, and compliance has shown to be better. The biological effect can be assessed, the disease can be downstaged, improving resection rate, and also we can tackle the subclinical micrometastasis early. So systemic therapy in resectable non-small cell lung cancer, locally advanced, is not been a new concept. It's been there for 30 years now. And we all know that the earlier trials and the LACE meta-analysis showed benefit. Tumors more than 4 centimeters, high-risk features, and nodal positivity warranted some form of systemic therapy to be added to surgery, because surgery alone was not enough, even if it was a complete resection. So what is the efficacy and evidence? This is a list of trials that has been published, and we started with Roth, Russell, and Depierre, the earliest studies, where they all showed that there was benefit in giving neoadjuvant chemotherapy in stage 3 patients who are about to undergo surgery. And then came the meta-analysis, which confirmed this, not a very big meta-analysis like the LACE meta-analysis, but it still had 15 randomized controlled trials with over 2,000 patients. And the risk ratio for the reduction of death was 13%, and showing almost a similar overall survival benefit as adjuvant therapy, which was again 5%. But what we were worried about, does it increase the 30-day mortality? Does it increase the morbidity? Because finally, you can't stop at neoadjuvant chemotherapy. You have to operate on this patient after that. So there was no difference in R0 rates, and there was no difference even across subgroups. Another meta-analysis by Zhang et al. Also confirmed the same. They included many more trials, and they showed a significant OS benefit with giving neoadjuvant therapy, and this was higher in females as well as locally advanced tumors in stage 3. There was no difference in post-op mortality or complications, and this was very, very reassuring. There were also some trials of neoadjuvant targeted therapy, but they really did not pick up much speed, because even though there was a modest response and pathological CR rates, there was a trend towards improved progression-free survival. Nothing actually translated into a better overall survival, and these were largely abandoned. So one of the groups tried to compare neoadjuvant with surgery versus adjuvant chemotherapy. They saw that even though 90% of the patients in the neoadjuvant group took chemotherapy, the 5-year DFS and OS was almost the same in both the arms. Now, if more number of patients complete their systemic therapy before surgery, most of the people were anticipating this study for quite some time to show some kind of benefit. But the criticism was that there were only 200 patients in each arm. It was a 600 patient trial with 3 arms, and therefore no difference could be demonstrated. And there are no other papers which have tried to replicate this. So coming to locally advanced lung cancer, there was a meta-analysis by Zhao, 18 randomized controlled trials, more than 2,000 patients with N2 positive status. So N2 is really the where the conundrum starts. What do? Do you resect? Do you give CTRT? Now there's specific data, and what is really better for the patient. So this meta-analysis actually showed us that NACT followed by surgery, followed by some more adjuvant therapy, had the highest overall survival benefit, and there were no excessive deaths in the multimodality arms. So now coming back to the most important question, what are we worried about? What are the difficulties we think may occur or actually occur? So we're worried about tumor progression. As we all know, not all patients will respond to this neoadjuvant approach. We are worried about the surgery being more difficult, therefore leading to less R0 resection rates. We are worried about the tissue fragility and delayed healing. And also we are worried about our patients being immunosuppressed when we are taking them up for surgery. already these patients are smokers, they are elderly, and they have locally advanced disease. So do they become more frail if you give systemic therapy first? And what happens to their pulmonary function tests, which are the most important determinant of their for quality of life? So there are some studies which showed about what happens to the perioperative complications in patients undergoing surgery after neoadjuvant therapy. This was an early study in 2000. Small numbers, 34 patients undergoing surgery after neoadjuvant therapy were compared to those who underwent upfront surgery. No increase in mortality, but I would like to draw your attention to this table where the major complications, life-threatening complications, are almost 3 times that of the arm which did not receive chemotherapy. 17% of the patients got re-intubated in the ICU. Almost 12% required a tracheostomy. So this really put off the surgeons from neoadjuvant therapy, and they were scared to adopt this approach. In 2001, MSKCC also published their experience, and this was a big number of patients, 470 patients with more than 80% receiving neoadjuvant chemotherapy. And even though the post-op complications were almost 1 in 3 patients had a post-operative complication, most commonly pneumonia and atelectasis, the mortality was comparable to other surgical series only. So the mortality did not increase, and right pneumonectomy was the only predictor of significant increase in mortality. So even from Kathy Albane's paper, where they had used induction chemo-RT, we know that right pneumonectomy is something that we have to be wary of when we are giving local radiation or systemic therapy. And this is again in stage 3 non-small cell lung cancer. 32% were post-neoadjuvant. Mean hospital stay is twice of what we normally see in patients undergoing surgery for lung cancer. Complications again 50%, but the mortality slightly higher, but they had a fair number of pneumonectomies and bilobectomies too. So after these older papers in the early 2000s, there are more contemporary series which have seen that can you still do pneumonectomy after giving neoadjuvant therapy? Because we are talking about locally advanced lung cancer, and pneumonectomy may be a necessary evil in a lot of these patients. You could do sleeves, bronchovascular sleeves even, you could do them, but in some patients, pneumonectomy is going to be required for a R0 resection. And in these patients, even chemo radiation may not be feasible in view of the large volume of the tumor. So there's no getting away that this is one of the surgeries we may have to perform. And when they looked at this, they saw that the major complication rates were much lower than the historic papers, that's 20%. And there was a significant bronchopleural fistula rate, but there was no difference in the type of subgroups. And the 90-day mortality was an acceptable 3%, which we see in high volume centers after pneumonectomy. Again, another paper looking at pneumonectomy, and here too, the mortality was not very high. So now we know that, minimally invasive surgery is the norm, is the accepted modality, is the accepted approach that we should be offering our patients, especially since we have level 1 evidence in the form of the Violet trial, which was published last year. So minimally invasive surgery is a better approach for patients who have lung cancer, who are undergoing surgery. But when we give neoadjuvant therapy, does this equation alter? So some papers on VATS after induction therapy, and they saw that the duration of surgery, blood loss, ICD, as well as the hospital stay was actually lesser in the VATS arm and not more. But a point to note is that a lot of the patients got converted. So this is a high volume center, Dr. Altorki's center, and here too, they had 12.5% conversions, mostly due to adhesions. Another paper which showed that the postoperative complications were 26% and the conversion rate was less than 10%, but no difference in postoperative mortality. So where are we now? This is the era of immunotherapy, like we all know, and we have had impressive papers being published in the last 3 to 4 years. The first study that came out from Bott's group was a phase 1 trial of 22 patients where they were just experimenting, giving immunotherapy, neoadjuvant nivolumab in resectable non-small cell lung cancer. Most of the patients were stage 2 and stage 3. They converted half the patients from minimally invasive to open surgery, but they saw that the major complications were not too bad and there was no postoperative mortality. So that was really significant and reassuring. But what they noted about surgery after immunotherapy was that there was a lot of inflammation and fibrosis, especially in patients who had a good pathological response. Patients were inundated with pneumonitis, other endocrine abnormalities, and the conversion rates were higher. So if we want our patient survival to improve, there is going to be a trade-off. The surgeons need to adapt their surgery, maybe train themselves and retrain themselves to be able to do minimally invasive in these patients as well. There are a lot of studies that have been published, and the earlier studies said there were a lot of patients being converted to open surgery. Then came the phase 3 trials, and here we saw that the pathological complete response rates were increasing. The patients had good survival at 12 and 24 months. And then people started adding chemotherapy to this neoadjuvant immuno. The Nadeem trial, which showed an impressive overall survival of 90% at 24 months, really set the benchmark for the FDA as well as surgeons and medical oncologists all over the world to adopt this strategy. And recently we saw the phase 3 trial being published, which showed the event-free survival at 1 year was significant. But we have to remember that this study has to be taken with a pinch of salt. It was initially planned as a 3-arm study, and the Nivo plus IPI arm was discontinued. But we are not sure, and the authors have not indicated if the statistics were recalculated after discontinuing the 3rd arm. They had highly selected patients, most of them ECOG 0, high volume surgeons who performed more than 500 lung resections per year, and tertiary centers of expertise where failure to rescue is very, very low. So we all know that we now have to adapt ourselves as surgeons to be able to perform surgery, not only after neoadjuvant immunotherapy and neoadjuvant chemotherapy, but also do it minimally invasive. But how do we determine which patients are really going to do well? Because after all, quality of life is also an important endpoint, and it's not just all about survival. So does administering neoadjuvant therapy impact the pulmonary function? A few small studies where they have done PFT pre and post neoadjuvant therapy, and they saw that there was a significant reduction in the diffusion coefficient for carbon monoxide, including the single breath as well as the alveolar volume, but there was no difference in post-op complications or mortality. Another study showed that the major complications were 30% when there was an 8% reduction in pulmonary function. And this is from Dr. Serfolio's group, and we know this is a very high volume center. So a Japanese paper which looked at pulmonary rehabilitation while the patient is receiving neoadjuvant therapy saw that those who were smokers and those who had respiratory impairment actually did better if you started the pulmonary rehab during the neoadjuvant phase of the treatment. So what have we seen so far? We looked at these 6 years, 2013 to 2019, and 16% of the patients in our lung surgery database had actually received neoadjuvant. The indications were mostly for N2 disease, a few others, and the histology was mostly adenocarcinoma. These were the regimens that were used. And we saw that the intraoperative parameters, such as the blood loss, the operative time, and the mean hospital stay was slightly higher compared to the patients who were undergoing upfront surgery. But major postoperative complications were not too worrying. That is Clavendino grade 3 or more, it was 13%. And the mortality remained at around 3%, which is what we see with upfront surgery also. So neoadjuvant therapy is safe, it is efficacious, but we also had a lot of conversions. So in our video-assisted thoracoscopy group, 7 patients out of 26 got converted. So just concluding, neoadjuvant therapy is now going to become the standard of care. Whether we like it or not, we have to accept it and we have to live with it. This is the time when multidisciplinary joint clinics are really, really essential, where all the stakeholders need to sit down together and plan the treatment. Contemporary series have shown that surgery after neoadjuvant therapy is not so bad. The side effects are acceptable. Extensive resections as well as minimally invasive surgery can be safely performed after neoadjuvant therapy. We need to repeat the lung function test pre and post neoadjuvant. Neoadjuvant immunotherapy is no longer the new kid on the block. It is the standard of care already in the Western world. And when it becomes affordable in our country, we too are going to have more and more patients who have received neoadjuvant immunotherapy and will be coming up for surgery. And the future therapy will be biomarker based. With that, I would like to say thank you, and I'll be happy to take any questions. No questions? Thank you.